Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's panel discussion, or we can say topic very important to each one of us. And it is my privilege to welcome all the participants on today's live session, as we all are gathered here to share commitment to advancing maternal health and ensuring better outcomes from mother across our nation. And the theme for today's program is Maternal Sepsis, a national call to action. Maternal sepsis remains one of the leading yet preventable cause of maternal morbidity and mortality worldwide. Timely recognition, rapid interventions, and coordinated healthcare responses are critical saving lives. This session for raise awareness, share evidence-based strategies, and empower healthcare providers to take proactive steps in tackling processing challenge. And so this we have our eminent host, none other than Dr. Sharda Jain, ma'am. And let me share some of the achievement of ma'am. Ma'am is Senior Consultant, Obstetric and Gynecology Department, Director, Life Care Center, Life Care IVF, and Expert Ethical Committee (NMC), Secretary General, Delhi Gynecologist Forum, Founder and Chairman for North India Gynecologist Forum. And without any further delay, I would like to invite ma'am and hand over this session to ma'am. Ma'am, stage is yours. You can proceed from here.
Perfect. So thank you for us, and my thanks to Met Talks for giving this national platform to talk on maternal sepsis, uh, a national call for action. What could be a better day? Today is a World Infection Day, and as the dedicated day itself says that uh, sepsis is one of the big causes of death of humanity. As far as the five facts are concerned, beside it is a major cause of death, there's a lot of people who are vulnerable to infection. And as you all know, there are people who have anemia, people who are obese, people who have diabetes, who have a low immunity. These are the ones who are vulnerable. One thing is also very clear, that once the infection is the cause, the death is totally preventable. And at the same time, if failing to detect the disease, it progresses rapidly. And once it is from infection, it is only sepsis, where there's an organ disarrangement. The sepsis rate is something like 10%, but when it goes to shock, the mortality rate comes to almost 50%. So, what is needed? The needed is that advocacy is needed. A lot of training is required for creating a public awareness, and the critical gaps which are there with doctors and the community have to be plugged. So coming back to maternal sepsis matters. You'll be surprised to know that sepsis was earlier around 12%, it was causing the total maternal deaths, and now it stands at 24 to 25% of maternal deaths in India. The sepsis is responsible. The sepsis is often silent initially, but can progress rapidly to shock and multi organ failure. And I just told you that once a septic shock occurs, the mortality goes to almost 40%. Most deaths are preventable with early recognition and a prompt management. The pregnant woman is at a higher risk because of the lower immunity, because of rampant anemia in our country, and malnutrition. At times, in a periphery, the prolonged labor takes place, and these are the ones which will determine that one has infection. So today we are going to have two speakers. Both are stalwarts. Dr. Deepti Naab, who is the president of Delhi Gynecologist Forum East, she is going to speak on red flag signs, because red flag signs should be known by everybody who are health workers, health professionals, especially the doctors and nurses. And then Dr. Shashi Lata Kabra is going to speak. She's again very senior consultant, has been dedicated herself as far as prevention of maternal mortality. She's going to talk on the first hour treatment. So first to start with, we will ask Dr. Deepti Naab to give her presentation. Dr. Deepti Naab.
Good evening, everyone. Shall we start with the presentation?
Please, yes, please go ahead.
Paras?
Faraz, please help. Yes.
Okay. So, what are the red flag signs? Before we start, let us talk about what is sepsis. Why are we talking about it? So, as per WHO, the definition is it is a life threatening organ dysfunction caused by dysregulated host response to infection. And please note the word infection. This condition occurs when the body's immune system reacts extremely to an infection, leading to damage to its own tissue and organs. If not properly recognized and treated, sepsis can progress to septic shock, multi organ failure, and eventually to death. Why does it matter? Because in India, even till date, despite all the facilities we have, it still is responsible for 24 to 25% of maternal deaths. And every maternal death from sepsis is a missed opportunity of early detection. It should not happen at all. A pregnant woman or a woman who has given birth or had an abortion or had a miscarriage in the last 6 weeks is at higher risk of infection than other healthy adults. And why is it so? Why is sepsis more common in pregnancy? So let's talk about the whys. The altered immune response. You see, this is a normal physiological change in pregnancy. There is a change in the immune response, and this is important as to why. Because this change is to protect the baby. But then what happens? The mother's defense system goes down. She is unable to respond adequately as she would have, or like for any other adult who's not pregnant, to any invasion of any germ, bacteria, virus, or anything. Then there are certain anatomical changes because of the pressure effect of the gravid uterus on the ureters, on the kidney, on the intestine. So these are all normal physiological changes. They are bound to happen, but then they eventually become responsible for proceeding towards sepsis. Procedural factors. Now, delivery will occur, whether it is a normal delivery with a vacuum or a forceps application or a C section. Delivery has to occur, procedures will occur. That is again normal. But then all of these factors will again become one of the reasons for increased incidence of sepsis. Normal physiological mimicry. Now, like I mentioned, there are so many changes which occur in a pregnant woman which are physiological. Her heart rate will increase, her breathing rate will increase. Now, these are the very signs which will occur in sepsis. Her blood pressure will be low. These are all normal in pregnancy, but unfortunately, and what we need to understand are these are the very things which also are the red flag signs for mimicry. So that is why the reason that there is a delay in the diagnosis, and that is where the healthcare workers, us clinicians, need to be alert. What are the contributing factors? Home deliveries, unbooked cases. Unfortunately, home deliveries, they are in themselves an invitation to sepsis. Anemia. Anything less than 12 is to be considered anemia. Malnutrition, unfortunately, even till date, there is approximately 35 to 45% of pregnant women in India who are still malnourished. And then there could be comorbidities like diabetes, HIV, and tuberculosis, which are prevalent. Then there are certain contributing factors related to obstetrics themselves. A prolonged rupture of membrane. It has been more than 18 hours since the bag of water has ruptured. Prolonged labor with multiple vaginal examinations. Anything more than 20 hours in a primary should be a red flag, should be a warning for us that there is something wrong. Any operative intervention, especially if there is an emergency C-section, if there are retained products of conception. Unfortunately, these are the source of the nidus. They invite bacteria and other harmful organisms. Unsafe abortions, fortunately, because of the awareness and because of our own procedures and the MTP Act, now the incidence has gone down. Then indwelling catheters, IV lines, any invasive procedure, anything which is not to be there, these are all, they provide a free entry for the germs to enter. A preterm, premature rupture of membranes and choriomyelitis. These are all contributing factors to sepsis. So, what is the preventive measure? One and the most important preventive measure is early recognition. So, what are the red flag signs which should indicate, or you should start suspecting that this woman is having sepsis? She's looking unwell. She's looking confused. Her mental status is little, she's not what she is. She has a high temperature or a low temperature more than 38 or less than 36. She has a low blood pressure. Mind you, I just mentioned that low blood pressure is a physiological change. But if the systolic blood pressure is low, then you should be alert. Increased heart rate. Again, I mentioned that increased heart rate is a physiological change. But increased heart rate without any cause and persistent should raise your antenna, should start, ringing that there is a problem. There is a decreased urine output, less than 30 ml in an hour. She's breathing fast, respiratory rate more than 24, should alert you that this is something which we should be careful. I should look into it. So, what are the universal red flag signs? If there is increase in the heart rate, if there is decreased urine output, if there is jaundice, if there is temperature, fever, or less than 36 degrees centigrade, if there is a rise in the systolic blood pressure, these are universal red flag signs which every obstetrician should be aware of and should not miss a chance to look out for them. And this is something very nice. This is a slide meant for the general public. If you have any of these symptoms during or after pregnancy, you should contact your healthcare provider and get help right away. And in case you can't reach your provider, please go to the emergency room. Remember to say that you are pregnant or have been pregnant within the last 6 weeks. So, what are the urgent maternal warning signs for all the women out there? Headache that just won't go away or it gets worse over time. If there is a dizziness or a fainting attack, or if you're having thoughts about hurting yourself, postpartum depression is a very well known entity. If there are changes in your vision, if you have fever, if you have trouble breathing, if there is chest pain or fast heart rate, if you have severe belly pain that just does not go away with any kind of a medication, if there is severe nausea and throwing up. So this is what happens in the first trimester of pregnancy, but it is not like that. And every pregnant lady comes to know that this is unlike the bonding sickness of the first 3 months. The baby's movements have stopped or they are slowing. If there is a vaginal bleed or a leak during pregnancy, if there is swelling or redness in the pain of your legs, extreme swelling of your hand or on your face, or whether there is overwhelming tiredness. These are warning signals for the mother. Please immediately contact your healthcare worker, then let her have a look into it. So, in the end, I would say a mother's life is not to lose. She is the world a child will choose. To let her die is a cruel wrong. Protect her life, protect your earth, for every mother is endless worth. Thank you.
Thank you, Dr. Deepti, for giving a
Ma'am, you're muted.
Thank you very much, Dr. Deepti, for giving a for an inspiring talk and giving an insightful, on what is the preliminary red flag sign. जो भी लोग सुन रहे हैं उनको ये पता होना चाहिए कि these are the signs when they have to contact. Now coming to the main part of the talk. The main part of the talk will be done by Dr. Shashi Lata Kabra. Earlier it was said that for every emergency there is the first hour is the critical hour, but as for the sepsis is concerned, maternal sepsis, earlier it was 6 hours bundle, then came 3 hours bundle, and now it is 1 hour bundle. So now Dr. Shashi is going to make it roll out this treatment plan in the first hour and how to save every mother. Every mother is very important, as Dr. Deepti just now said, and every child also has should be given a full privilege to live his or her life. So over to Dr. Shashi Kabra. Shashi Kabra, I remind again that she had been a past president of Delhi Gynecologist Forum Southwest, and now she remained the secretary of North India Gynecologist Forum, and now she's been dedicated to work on preventable maternal mortality. So over to you, Dr. Shashi Kabra.
Thank you so much, ma'am. Thank you so much, Mr. Faraj, for giving me this opportunity. So, sepsis is a silent killer. The 2017 WHO definition of maternal sepsis is described as a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. And the extreme of this is septic shock, which is a clinical condition when the mean arterial pressure cannot be maintained more than 65 millimeter of Hg. Mean arterial pressure means diastolic blood pressure plus pulse pressure divided by 3. That I will show in further slides. So, all over the world, the commonest cause of maternal mortality is postpartum hemorrhage. Next common cause is hypertensive disorder. But sepsis used to contribute 11%, and now, as Dr. Dipti said, almost reaching 25%. The incidence is increasing, and we have to take an urgent action. Without prompt recognition and appropriate treatment, it can quickly cause death. And even if treated, it may lead to long-term morbidity, neonatal sepsis, preterm birth, admission to NICU, and increased perinatal mortality rate. Ma'am has said that even the child is very important, even the newborn is very important. Do you know that every 4 minutes a woman dies from sepsis-related cause somewhere in the world, with the greatest burden borne by the women in low and middle income countries? WHO says that maternal infection is more common than you think. It is beyond our imagination and it can kill. So we have to take precautionary actions like practice clean care, diagnose early, and treat promptly. Our health facilities need investment in clean water and sanitation, infection prevention and control measures. That's a big, long chapter, training and equipment supplies. So today we will discuss evidence-based management of maternal sepsis, which is an evolving challenge for all of us. These factors have been described by Dr. Dipti. There is no harm if you revise it again, looking at my slide. She has covered almost everything. The one very important thing is group A streptococcus infection. They are called gas. And obstetric causes, she has said, prolonged rupture of membrane, cesarean birth, vaginal trauma, return products of conception, amniocentesis, multiple gestation. Then obesity is an independent factor. Diabetes is also a factor. And you can read all these factors. Now, the common causes, common sources among the obstetric are septic abortion, chorioamnionitis, and in non-obstetrical cases, UTI, pneumonia, and appendicitis. Even assisted reproductive technique and multiple gestation increase the incidence of sepsis. So, this red chunk is by Escherichia coli, then the next common is Staphylococcus and then Streptococcus. And as Madam has said in the beginning of the talk, that sepsis is a disease of every organ. It can finally involve a single organ followed by multiple organ, morse, and then death. So in central nervous system, it can lead to altered mental status, cardiovascular system, hypotension from vasodilatation, and third spacing. Pulmonary system, ARDS. This is called adult respiratory distress syndrome. There are two types of pulmonary edema. One is due to infection, which is ARDS, and another is due to fluid overload. This is cardiogenic pulmonary edema. So this pulmonary edema will not respond to fluid, but to antibiotic. Gastrointestinal system, paralytic ileus. Hepatic system, hepatic failure. Urinary system, acute kidney injury. Hematological system, thrombocytopenia or disseminated intravascular coagulopathy, a very serious and lethal condition. And endocrine complications are rare, but still they may happen. So it is the time that we should think, could this be a sepsis? If a woman is looking unwell or is complaining of any complaint which we are not able to understand, think of sepsis. So we have to take a thorough history and examine the patient properly. Red flag signs, Dr. Dipti has already said, these are the red flag signs. Temperature, even hypothermia is a cause. is a sign. Then sustained tachycardia, breathlessness, abdominal and chest pain, diarrhea, vomiting, and severe abdominal, or if the patient is generally looking unwell. Now coming to the diagnosis. Now many people say many things. Some talk about Q-SOFA score, some talk about obstacle modified SOFA score, some talk about Muir score. But you see one thing, all these charts require a lot of investigations. So please believe in your own clinical findings, clinical acumen. And the most important thing which can help in quick recognition of sepsis is SIRS criteria. Sepsis inflammatory response syndrome criteria. The criteria are temperature more than 100.4 degree Fahrenheit or less than 96 degree Fahrenheit, heart rate more than 90 beats per minute. In pregnancy, there is a physiological increment of heart rate, so it is fixed at this stage. Then tachypnea more than 20 breaths per minute, and white blood cell count less than 4,000 or more than 12,000, or there are more than 10 immune band forms in peripheral blood smear. And see, when these two criteria are present, we call this sepsis inflammatory response syndrome. And when we can, then what we have to do, you have to find the focus of sepsis. Where is the sepsis? And once you find the sepsis, then the diagnosis becomes sepsis. And if it leads to any organ dysfunction, then we call it severe sepsis. And later on, it leads to multi-organ dysfunction. Then it is called MORS and may lead to death. And this is the obstetrically modified SOFA score, because the pregnant women already have little tachycardia, more tachycardia. So this is the score: systolic blood pressure more than 90, respiratory rate less than 25, and altered mentation. The score is 1 if they are not alert. I put a big cross over here. Why? Because this condition happens when the patient is already in an advanced state. The sepsis has got an effect in the brain, and her mental status has altered. So please don't utilize this tool to pick up the sepsis early. You are picking up the sepsis early with SIRS criteria. I think I'm clear on this. So this diagram I myself made to make you understand better. SIRS versus SOFA score. That means early versus advanced sepsis detection. SIRS is the fire alarm. It is alarming you, please, I am a sepsis and please treat me. And SOFA, the damage is already done. So no point intervening here. Please try to pick up it here. So this is another representative picture that we have to act here. Now, you see, Madam has already said when there is sepsis, the mortality is 16%. And when it is severe sepsis, the mortality is 20%. And when it is septic shock, the mortality is 40 to 70%. So don't allow the patient to reach in this stage. So the Q-SOFA score does not define sepsis. Rather, it is a rapid method of identifying those patients at high risk of developing severe complications who require more aggressive therapy. This is a pictorial representation how sepsis spreads. Infection plus organ dysfunction is called sepsis. Infection, identify source and cause of infection, and then you do controls source of infection and initiate appropriate antimicrobials and treatment. And if there is organ dysfunction, then point of care assessment of organ function, and look for physiological parameter and fluid resuscitation, respiratory support, and hemodynamic support. So look at this picture. It is the golden 1 hour. We have to do 6 works. And you see beautifully, look at this diagram. Give 3, take 3. What are you giving? Antibiotics, fluids, and oxygen. And what are you taking? Urine output, blood culture. You are monitoring urine output. Serum lactate. Yeah, serum lactate, if the facility is available, you do it. Otherwise, it is not required for the initial management of sepsis. Now, you administer oxygen if the patient's saturation is less than 94%, and you give it at a very fast rate. Then the first most important step is take blood culture. From one hand, you take blood culture, and from another hand, you give a broad spectrum antibiotic. You do not know still the cause of sepsis, so please give a broad spectrum antibiotic. Then you give intravenous fluids, 30 ml per kg of body weight. You have to initially resuscitate the patient with intravenous fluids, and if the patient does not respond to that in 2 to 3 hours, and mean arterial pressure is not maintained up to 65 millimeter of Hg, then we add vasopressors. And we need to have a intake output chart and urine output, otherwise also very necessary to see whether if any kidney injury has occurred or not. So remember the word take 3, give 3. So this is the pictorial representation. Here you are taking the blood culture and giving antibiotic. If this facility is not available, no problem. Then here you are administering the antibiotic. Then you are beginning the intravenous fluid at 30 ml of per kg of body weight. And if the BP still can't be maintained even after IV resuscitation, then you are giving vasopressors. So initially when you go through the literature of sepsis, then you will see that about few years back it was a six steps and 6 years, 6 hours bundle. Then later people thought that it is not good, so they reduced it to 3 hours, 3 hours 6 steps, and recently it has been shifted to 1 hour bundle. But what is the harm if we can still make further improvement? And you can't believe, but we are doing it. We are doing a 10-minute bundle approach in DDU hospital, and we are perfectly able to do it. So now you have suspected sepsis, now you have to investigate. So these are very simple investigation which I have written here, and anybody can do it. It is available in all facilities. No hi-fi investigation. CBC, peripheral blood smear, you can find toxic granules in peripheral blood smear, urine REME, urine CS, high vaginal swab, blood urea and creatinine will let you know the kidney effect. Total bilirubin, AST, ALT will let you know whether liver is at fault. Chest X-ray, if there are crepitations in the chest. BTCT is a very common bedside test. You do a clot retraction test, which has become a lost art now, and PT-INR, you do it if the facility is available. Now I kept these 4 investigations in another box. CRP, if the facility is available, you do, otherwise it is not required. It does not help in starting the management of sepsis. Little bit prognosis it helps, but there are other parameters also, clinical parameters to see the prognosis. Then lactate, if it is available, you do it, but even without lactate, you can manage. Then ABG analysis, it should be done if it is available, but if it is not available, then it is not hampering your initial 1 hour management. Then wherever there is wound, which is a cause for sepsis, wound infection, then take a wound swab, or if the throat is source of infection, then you take a throat swab. And in some cases, you require imaging, like for retained products of consumption. Many times you require an ultrasound to see whether the products are there or not. So these imaging facilities you may require. These are the golden words of wisdom. Why I am again and again emphasizing that you take blood culture and within 10 minutes, you take blood culture and give antibiotic, a broad spectrum antibiotic, because antibiotic treatment, if it is delayed, then the mortality increases by 7 to 8% with each hour of delay. That means you started thinking that I will give antibiotic, I will ask my consultant and do it, and you wasted 3 to 4 hours. That means 8 4s are 32, have already increased the incidence of maternal mortality by 28 to 32%. Use a broad spectrum antibiotic until the culture report is available, and review IV antibiotic every 24 hours. If the patient is not responding in 24 hours and her vitals are worsening, please add another antibiotic. Suppose you are using peptides, you may have to add vancomycin. And stop antibiotic or change to an oral alternative as soon as appropriate. So when you make a diagnosis of peripheral sepsis, then the broad antibiotic of choice is injection piperacillin tazobactam 4.5 gram IV 6 hourly. If already the kidney is at fault, then you can give the renal dose 2.5 gram. But everybody should remember this. At that particular time when the patient is requiring this antibiotic, don't ask others what is the dose, what is the dose. You should know that this is peptaz and the dose is 4.5 gram. If peptaz is not available, or if the patient is not responding in 24 hours treatment to peptaz, the another good choice is a combination of meropenem and clindamycin. These are the photos, real pictures. I have not taken it from internet. These are the pictures I have taken from my own ICU. If the patients have received antibiotics elsewhere and have been referred to you, or she is already in septic shock, or she is intubated because of lung edema, then these antibiotics will help a lot. Imipenem and vancomycin. Vancomycin gives a very good coverage to MRSA that cannot be given by peptides. And sometimes you have to add teicoplanin after vanco. So the sequence is peptides, tazobactam, metrozil, or meruclinda. If the patient is not responding in 24 to 36 hours, add vanco. If the patient is not responding in one day, you add teicoplanin. You should never wait for any culture report. Culture reports sometimes come in 3 days, sometimes in 5 days, sometimes in 7 days. By that time, if you don't give treatment, patient will die. Then how will you monitor? By respiratory rate, pulse, BP, oxygen saturation, temperature, hourly urine output, and she may require admission in a high dependence unit for enhanced maternal care. So, how will you monitor the response to treatment? It should be evident within 1 hour after completion of fluid resuscitation and giving intravenous antibiotics. And I'm telling you that it is my own experience in my DDU hospital where there are 10,000 deliveries per annum. And we get referral cases from RKRM Hospital, from Mata Gujri Hospital, from Delhi Kent Hospital, from Acharya Bhikshu Hospital, from Guru Gobind Singh Hospital, and from Patel Nagar Hospital, and from Dadadev Hospital. And I've seen this dramatic change within 1 hour as soon as I've given IV fluids. One day I had given IV peptides. After suspecting sepsis, I had given IV peptides to that patient. She was just drowsy and was not responding and was irritable. Only within 1 hour, she started saying to me, "Madam, I'm feeling well. What have you given to me? मेरे को खाने के लिए दो." So this is the miracle which happens after giving antibiotic. And always involve a senior consultant and try to use a multidisciplinary team. Sometimes we need anesthetists, we need physician, we need surgeons. It's not a big thing. Both specialties are always available. So the consultant level communication and decision making is required when women do not improve and respond. The incidence of thrombosis increases in sepsis, so you should give low molecular weight heparin according to the weight of the patient. And now the next important thing, you have given IV fluid, you have maintained BP, and now you have to look for the cause of sepsis. If you are giving only antibiotic or not looking for the cause of sepsis, that is there only, and then the sepsis will again revert back and patient will again become sick. So find out the cause of sepsis, which I have already told you that you can take help of imaging modalities also. So return products of conception, if they are found, they need to be evacuated. Do not defer definitive surgical treatment if the maternal condition does not respond to treatment. And sometimes we need to do laparotomy to eliminate the source of any intra-abdominal sepsis or intra-abdominal pus formation. And sometimes we may have to do hysterectomy for sepsis. In my 27 years practice in Deen Dayal Upadhyay Hospital, in 4 cases, I performed a hysterectomy because of sepsis. Wherever I was pricking on the uterus, pus coming out from the needle prick point. So immediately I understood that I have to perform hysterectomy. Otherwise, how much antibiotic do I give to the patient? This patient will not respond. So the decision making is also very important. Then you have to drain the abscess, or you have to in some cases you have to put the pigtail or surgical interventional radiology. These are required. Sometimes debridement and wash out of the suspected intra-abdominal infection. And suppose the sepsis is due to chorioamnitis, then you have to expedite the delivery. And sometimes plastic surgery and debridement for necrotizing fasciitis. This is rather uncommon, but we see once in 1 year. So these are the indications when the patient needs to be transferred to a high therapeutic unit or a SDU, high dependence unit. If hypertension less than systolic 90 millimeter of systolic BP, or lactate level are raised, or patient is having pulmonary edema, or she requires mechanical ventilation. SpO2, every doctor, very simple thing, every doctor should keep a SpO2 measuring machine. It is not costly, available in 700 to 7,000 rupees. Keep one, and it will give you instant information about the SpO2 of the patient. If it is less than 94, give oxygen. Then if the patient has kidney injury, decreased conscious level, or multi-organ failure, then you should keep the patient to a higher facility. So now this is a diagram in nutshell. Only this one slide will tell you everything about sepsis. 1 hour bundle, cultures prior to antibiotic, broad spectrum antibiotic, crystal alerts and vasopressors if BP is less. Investigation, imaging studies, if you want, wherever it is applicable. Source control, priority, and may involve abscess drainage or delivery of the fetus. Fetal consideration, electronic fetal heart monitoring at 24 weeks of pregnancy, and steroids for maturity of the fetus, and complication of prevention, early enteral feeding, and DVT prophylaxis. Avoid hyperglycemia. So this one slide can tell you everything about sepsis. Now, next step is de-escalation and step down. It should allow women to either exit the sepsis pathway altogether or follow a different pathway. If a good response to sepsis treatment is demonstrated, a clear plan for ongoing monitoring criteria for escalation and antimicrobial review should be made by the obstetric team as part of the step down from the sepsis pathway. Further information on investigation may confirm alternate diagnosis and treatment pathway. Not all deterioration due to sepsis is due to sepsis, and holistic review and finding diagnosis is important. Now, few words about antimicrobials. You had to have little bit knowledge beyond knowing cephalosporin and amoxicillin. So, co-amoxicillin is a very good antibiotic, but it does not cover MRSA. And MRSA means methicillin-resistant Staph aureus, and it is a very common infection in maternal sepsis. So, it does not cover MRSA and Pseudomonas. Then metronidazole, it only covers anaerobes. So if you have to assess the patient daily, and you can replace metronidazole with clindamycin. Clindamycin is a better anaerobic, and it can also cover a few methicillin-resistant Staph aureus. So, and it covers most of the streptococcal and staphylococcal infections also, and it decreases maternal mortality significantly. And then it is not renally excreted and not nephrotoxic. So it's a very good antibiotic for management of maternal sepsis. Then piperacillin tazobactam, it covers all except methicillin-resistant Staph aureus, and that's why you need a backup of vancomycin if the patient has MRSA infection. Then gentamicin, it's a common drug, everybody knows about this. Nowadays, few literature says that try to avoid gentamicin in maternal sepsis, but we do not give gentamicin. And if the methicillin-resistant Staph aureus is also resistant to Clinda, because I've told you that to assess the patient every hourly, and if in 12 to 24 hours patient is worsening and is not responding to even Clinda backup, then quickly you shift to vancomycin. Day before yesterday only, I saw patient's WBC was 40,000, and rest other things were normal. Pulse was maintained, BP was maintained. There were only few crepes in the chest, and then I asked the doctor, my junior doctor, what was the WBC day before. So she told me it is 26,000. And after giving our antibiotic, peptide and everything, this has become 40,000. I did not waste even a single second. And I said, you give Vanco. According to her weight, she was approximately 60 kg weight, and we had given her 1 gram vancomycin. And in 2 to 3 hours, my doctor called me, my junior doctor called me, madam, patient was drowsy, now she's responding well, and her crepes have gone. So that is the magic caused by antibiotics. This decision making, when to change the antibiotic, when to give the backup, that is very important. So this is mean arterial pressure. It is high time that we should all know what is mean arterial pressure. 1/3 systolic minus diastolic blood pressure, that means 1/3 of pulse pressure plus diastolic blood pressure. Now, suppose I've given IV resuscitation with fluids and everything, and still the patient's BP is not maintained. It is usually understood in 2 to 3 hours of IV infusion. So what to do? You have to maintain her BP. So worldwide, the only one drug of choice as a vasopressor for a septic shock is noradrenaline. What is it? Noradrenaline. So you are giving initially crystalloids. Ringer's lactate is the fluid of choice. It is Ringer's lactate, which is the fluid of choice, even in PPH, also in sepsis. And if the BP is not maintained, mean arterial pressure up to 65, add noradrenaline. The starting dose is 0.05 to zero point 0.1 microgram per kg per minute. You should titrate it by increasing very slowly by 0.02 to zero point 0.05 microgram per kg per minute every 5 to 15 minutes to maintain mean arterial pressure more than 65. Typical maximum dose is 1 to 2 microgram per kg of body weight per minute. And you can use, it is better that you use a central line. Central line every anesthetist can put. It is not that uncommon. In our hospital also, all such patients are treated with a central line. But if you want to give it temporarily, then you can give through a peripheral line. Now, you have given noradrenaline, but the patient is still in shock. Her BP is not picking up. So, what is the next vasopressor? It is vasopressin. Second vasopressor of choice is vasopressin. I will not go into the doses because this is a high level critical care, but I will just tell you the name so that at least you are aware. So the first vasopressor of choice is noradrenaline, second is vasopressin, and third is dopamine or dobutamine. So you remember at least these three. And after that, you can add hydrocortisone also, 200 milligram in 4 divided doses. Now this chart I made myself. It is my nature that I never copy anything from this. I think that what I want to teach, I have to make it according to my expectations. So as per my experience, I realized that we should all know these antibiotics very well. So when during my earlier days, I used to ask in ICU when I did not know anything about these details. You tell me what is the dose of peptides. अच्छा आप बताइए peptides की dose क्या. अच्छा आप बताइए meropenem क्या. अच्छा ये बताइए meropenem को mix कैसे करना है. अरे why are you asking? Then I realized why should I ask everyone? I should remember everything. I should know the methods how to constitute these antibiotics. So then I made this particular chart that everybody should know about this. Piperacillin tazobactam, 0.5 gram is the dose. It is to be given 6 hourly, and if the patient has little renal stress, then we give 2.5 grams 6 hourly. The route is intravenous, and the spectrum is very broad. Then come to meropenem. The dose is 500 or 1 gram 8 hourly. If women is more than 55 kg, give 1 gram. In renal dose is half. Give intravenous, and the spectrum is very broad. But vancomycin does not have a broad spectrum. It is a narrow, but then it covers specifically the methicillin-resistant staph aureus. The dose is 1 gram. You give it 12 hourly. Sometimes we give 8 hourly also, and the route is intravenous. Then Clinda. The dose is 300 to 900. Usually the women of our country who has a middle type of build, they require 600 milligram. Give intravenous, and the spectrum is narrow, but they cover a lot of Streptococcus and Staphylococcus, and at the same time they cover a few MRSAs. Then teicoplanin, loading dose is 6 milligram per kg of body weight. I request you to take a screenshot of this slide, and dose to be halved from day 4. It can be given intravenous or intramuscular, and the spectrum is narrow. But it is very good. It will cover MRSAs. I always love to share this slide just to tell you that you should know about these antibiotics, and this also tells you that I have worked in my ICU. These are the pictures which I have taken myself. This is piperacillin tazobactam combination. This is meropenem. 1 gram is also available. 500 milligram is also available. This is vancomycin. Clindamycin, a very good drug, life-saving drug. Teicoplanin, 400 milligram vial is usually available. And this is a chart, when I used to teach postpartum hemorrhage, I made obstetric hemorrhage chart. It works as a checklist, what work has to be done, and documentation also, whether we have done it or not. And when you do good documentation, if you have done any work and not documented, that means work is not done. So if you do good documentation, it will save you in court of law. So this is a type of documentation form which I was showing to you. The sepsis 6 steps, that 1 hour bundle steps, you can write this, like whether you called your consultant, whether you have given oxygen, you just mark it here. Whether you send blood cultures, IV antibiotics, IV fluid, monitoring, all this type of, you can customize this according to, as per your own hospital situations or circumstances. So this is finally the key interventions in the treatment of sepsis depicted in the figure. Within 1 hour, you have to do so many things. Obtain culture, serum lactate, administered broad spectrum antibiotic, initiate fluid. Why, I've repeated this many a times that obtain culture, give antibiotic, give fluid 30 ml per kg, but purposefully, so that after this lecture is over, you will be remembering it. Revision, revision, and revision. 30 ml per kg of body weight crystalloids. Ringer's lactate is the fluid of choice. And if mean arterial pressure is not maintained beyond 65 millimeter of Hg, you add vasopressors. What is the vasopressor? Start norepinephrine with a central line, if required for a prolonged time, or peripheral line, if required for a smaller time. Then you can give low dose corticosteroids, 200 milligram hydrocortisone in divided doses, and you achieve early source control using imaging studies if required. Then consider electronic fetal monitoring, consider steroids for maturity of baby if the baby is there, and avoid hyperglycemia, initiate DVT, and early enter with feeding. And now, towards the completion of my presentation, I share with you the top 10 pulse for managing maternal sepsis. First is recognition. Recognition is the key. Pul 1, always maintain a high index of suspicion for sepsis. The eyes can't see, but the brain does not know. So let your brain know that maternal sepsis is one entity which is a major cause of maternal death. Pul 2, implement a rapid bedside tool for detection of maternal deterioration. Move fast during the golden hour to save lives. Pul 3, implement sepsis bundle to facilitate rapid escalation care. Pul 4, laboratory and radiological studies are keys to search for etiology and source control. Pul 5, know your bugs, their likely origin, and that group A streptococcus can kill quickly. Pul 6, choose antimicrobials tailored to the most likely diagnosis. Pul 7, fluid resuscitation should be initiated rapidly for patients with blood lactate greater than 4 mmol, or whose systolic BP is less than 90 millimeter of Hg, or whose mean arterial pressure is less than 65 millimeter of Hg, and beyond the golden hour, escalation of the care for survival. So I feel it as a great honor and opportunity to deliver this talk on 13th September, which is the World Sepsis Day. Sepsis is life-threatening, but when caught early and treated promptly, it can be stopped. So my request to everyone, stop sepsis. Together we can. So thank you so much.
रामबाण ट्रीटमेंट बताने के लिए, and in fact she has made it very simple that this 6 steps for sepsis we must remember. It is a golden hour treatment, and as she said that within 10 minutes things can be done. Quick assessment, take cultures, 2 sets of cultures is important, aerobic and anaerobic. Broad spectrum antibiotic, I think nobody could tell you better what antibiotics to be used. And whenever you find a patient is not responding and the counts are more, escalate your treatment. One thing I just want to tell you, your fluids are like a drug. Everybody should know about it. Coming to the source of control, अगर पस है कहीं पर, नेक्स्ट मॉर्निंग नहीं होनी चाहिए, उससे पहले काम हो जाना चाहिए.
Clear.
The next morning should not sense should not come, it should be drained immediately. Previously we used to say that अगर कहीं पर पस है तो लेप्रोटमी करने के लिए हम लोग 24 घंटे वेट करते थे. अब now the concept is you start antibiotics and don't wait for 24 hours. This is what is very very important. And पेशेंट आपका वाइटल्स आपके इंप्रूव हो जाएंगे. उसका सबसे बढ़िया पहले मेंटल स्टेटस हो जाएगा. जब भी पेशेंट आपका पोस्टमार्टम पीरियड में अनवेल लग रहा है, सब कुछ ठीक है पर ठीक नहीं लग रहा, तो आप सेप्सिस सोचना शुरू कर दीजिए. एक तो ये वाली बात आपको जरूर याद करनी चाहिए. जैसे आपने ट्रीटमेंट में एक्सकलेशन चाहिए, आपको डी एस्कलेशन, जब पेशेंट आपकी इंप्रूव करने लगे तो आपको डी एस्कलेशन ऑफ एंटीबॉडीज आल्सो रिक्वायर्ड. एंड आई थिंक both Dr. Deepti has highlighted what are the red flag sign, and Dr. Shashi Kabra has highlighted what is the Ramban treatment, and you can see the magic appearing once you follow this particular treatment in the golden hour. So this is what I will say, that she has very rightly said, पहले इन्फेक्शन आएगी, फिर सेप्सिस आएगी, सेप्सिस के अंदर ऑर्गन डिसफंक्शन आएगा, एंड यू शुड रिमेंबर दैट पर्टिकुलर टेबल, क्या क्या आपको रह सकता है. बट एक बात बिल्कुल क्लियर है, मेंटल जब भी कंफ्यूजन उसको हो, ये वाली चीज बहुत इंपॉर्टेंट है, एंड यू फाइंड द बेस्ट रिस्पॉन्स कम्स बाय सीइंग that patient becomes more alert and the urine output and other things are great. So Dr. Deepti, you want to wind up? What is your last comment?
My last comment will be that this is preventable. Maternal sepsis is really
Maternal death is preventable.
Yes, it is preventable. You just need to. We had a talk sometime back, ma'am. We had talked about hand hygiene, and we had talked about that hand hygiene is the first step when you go and examine a patient in the ward. Hand hygiene is the rule. If you can maintain that, you have reduced almost 90% of chances of sepsis. And the second step would be to be alert.
And hand hygiene में भी आप बता दिए, खाली 20 सेकंड soap and water, 20 सेकंड, 99% infection.
Hand hygiene, nothing fancy is needed, साबुन और पानी, that is all. And hand hygiene, in fact, इसके बाद be alert. आप राउंड लेते हैं, आप पेशेंट को देखने जा रहे हैं, वो आपके पास अगर आई है, इमरजेंसी में आई है, one quick glance at her body language, the way she's looking at you, the way she's behaving, should be enough for a good clinician to know that there is something wrong, and you should start revising your steps as to how you have to manage it. You've taken her temperature, pulse, BP, SpO2, respiratory rate count किया, और जब तक ये सब कुछ हो रहा है, ठक 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 ठक, आपने उसको फ्लूइड स्टार्ट कर दिया है, आपने उसका ब्लड सैंपल भेज दिया, like Dr. Shashi has said, टेम्परेचर हाई हो या लो हो, इट्स अ वार्निंग साइन. उसका आप जब तक सिस्टर आप खुद ले लो, डोंट इवन वेट फॉर द सिस्टर, टेक जस्ट पुट द पल्स ऑक्सीमीटर ऑन वन साइड, स्टार्ट टेकिंग अ ब्लड प्रेशर. आपको दिख रहा है that she is not well, she's in sepsis. It is preventable. It is very sad if we lose a patient to sepsis.
Oh yes. If the treatment is not right, she will rapidly deteriorate. And खासकर जब भी स्टेफिलोकोकस होगा तो 2 घंटे में डिटोरिएशन हो जाएगी. So I think you have to 2 घंटे में डिटोरिएशन हो जाएगी. Dr. Shashi, your last comments.
मैडम मैं एक सिंपल सी छोटी सी स्मॉल थिंग बताना चाहती हूँ. मैडम हैज टॉक्ड अबाउट प्रिवेंशन. एक तो जहाँ हमें प्रोफाइलैक्टिक एंटीबायोटिक देनी है, हम उस समय हायर एंटीबायोटिक दे देते, थर्ड जनरेशन सेफलोस्पोरिन. So we should not give, as we should follow the ICMR guideline. You should give first generation cephalosporin, cefadroxil or ampicillin, so that when our patient develops infection, we should have some other medicine, third generation cephalosporin in our hand to start. Second thing, we have a place in our hospital which is called high dependence unit, labor room 2. Every day one patient is found with sepsis. कुछ नहीं, खाली मैं बेड साइड पे वहां पे देखती हूँ, 4 चीजें पूछती हूँ. पल्स क्या है, रेस्पिरेटरी रेट क्या है, टेम्परेचर कितना है, और डब्ल्यूबीसी. मुझे डब्ल्यूबीसी तो हर जगह होती है, एवरीवेयर, एनी सीएससी पीएससी सब जगह डब्ल्यूबीसी होती है. कोई भी 2 क्राइटेरिया मुझे पॉजिटिव मिलते हैं, पल्स 90 है, डब्ल्यूबीसी भी 18,000 बता दी, यू टेक कल्चर, गिव अ ब्रॉड स्पेक्ट्रम एंटीबायोटिक. मुझे कोई मेजर इन्वेस्टिगेशन की जरूरत नहीं है. इन ऑपरेशन थिएटर व्हेन आई सी द पेशेंट, आई ऑलवेज आस्क फॉर डब्ल्यूबीसी. पल्स बहुतों की 90 100 हो जाती है. यू कंसंट्रेट ऑन डब्ल्यूबीसी आल्सो. 20,000 डब्ल्यूबीसी, 19,000 डब्ल्यूबीसी, 40,000 डब्ल्यूबीसी. यहाँ यदि आपने ब्रॉड स्पेक्ट्रम एंटीबायोटिक नहीं दिया तो देयर विल बी अ प्रॉब्लम. इट इज द टाइमिंग ऑफ एंटीबायोटिक व्हिच इज वेरी इंपॉर्टेंट. आपने 1 घंटे डिले करा, यू आर इंक्रीजिंग द इंसिडेंस ऑफ मैटरनल मोर्टेलिटी बाय 7 to 8%. एक बार क्या बच्चे जो रेजिडेंट डॉक्टर्स होते हैं जूनियर, वो कहते, उसको मैंने पूछा आपने एंटीबायोटिक क्यों नहीं दी, 26,000 था डब्ल्यूबीसी और पल्स इसकी 100 थी. मतलब वो मैडम से पूछना था, पूछा. अरे यू डोंट वेस्ट टाइम. आपको मैडम कुछ नहीं बोलेगी, आप एक पिप्टास दे दोगे उसको, और बोल भी देंगे तो सुन लेना. आप दे तो दो, यू आर नॉट कॉजिंग एनी हार्म टू द पेशेंट.
नहीं डॉक्टर वहाँ लिख देना चाहिए whenever the TLC is more than 15,000 you have to give.
So
Yep.
we are following this only, madam. We are following this. And बंडल जो बंडल 6 घंटे का 3 घंटा हो गया, and the बंडल जो 3 घंटे से 1 hour हो गया, why not do it in 5 to 10 minutes? हम only 10 मिनट ही लेते हैं to do everything. One on catheter side, urinary catheter डाल रहा है, the other on IV drip, one on taking culture के लिए जिसमें ब्लड निकालते हैं, उस समय बाकी इन्वेस्टिगेशन भी साथ ही निकल जाती है. 10 मिनट में आराम से हो सकता है. Why to take 1 hour?
And the resuscitation fluid is crystalloid.
Crystalloid.
और इसके अंदर आपने 30 ml per kg है, 3 घंटे में देना है, बोलस की तरह से दीजिए. और आपने देखेंगे यूरिन धड़ा आना शुरू कर देता.
आप में इंटेंशन होने चाहिए.
So I think this particular talk on a World Infection Day on maternal sepsis is thing. I think we are thankful to both of you for enlightening everybody. Or maternal sepsis is one thing which is totally preventable, provided there's an early detection, early treatment, and you can definitely save the mother's life. So this source control is also very, very important. Very, very important. You should not neglect it. So thank you very much, both of you. Thank you very much.
Thank you, ma'am.
There have been no questions. So I think we're going to just wind it up here. Sarfaz? Hello? Anyway, we are
thank you so much, ma'am, for this interactive session, ma'am. Like, it was a wonderful discussion and presented by Sashi ma'am as well as Dr. Dipti ma'am. He has came with very practical approach to this topic. I hope like it will very much helpful to all the general practitioners who are and the college PG students coming into this field, ma'am. And you all are making this bridges for them easy to climb to the destination. And it was great honor to have you all on today's webinar on a very important topic, that is maternal sepsis. Until then, take care of yourself. We would like to see you in future also with different topics. And it was a great honor to host, to be a part of this webinar.
Thank you again, Met Talks, and thank you all of you. Thank you very much.
Thank you.